Hi, I'd like to introduce Dr. Berry from Michigan Medicine. She's a board-certified physician in spinal cord injury medicine. We are lucky enough to have her here at Special Tree as our spinal cord injury program consulting physician. She has graciously agreed to provide our staff with quarterly in-services to further our education on spinal cord injury medicine. Please welcome Dr. Berry.
When I was growing up in about 6th grade, I was absolutely mesmerized by the pathology of the spinal cord when I saw it under a microscope. And this is a cross-section of the spinal cord. And it literally looks like an upside-down butterfly. And I remember thinking to myself, like, this is the real Broadway internet, because it's essentially a highway system, okay? It takes information, processes information from your brain, who's in charge, and sends it all the way to the end of the spinal cord to do certain functions. And anytime there's an injury in this network broadband or this highway system, life changes. Okay? So Special Tree is CARF accredited traumatic brain injury, and we're working on up-titrating that for spinal cord injury. And this is the whole purpose of today's session, is to get us more acclimated in the nomenclature about what language do we use to qualify and quantify a spinal cord injury? And then what does that even mean? Who cares if we can speak the language? The answer is, what can we do with that language? What can we prognosticate? Okay? So I know there's some therapists in here and some nurses in here, so we'll try to keep it pertinent to everybody. Okay? So our objectives is to go over the spinal cord anatomy. There's something called the International Standards for Neurological Classification of Spinal Cord Injury. And this is your report card. This is how we speak about how your spinal cord injury has affected you and what you can quantify from it. The functional prognosis and a few outcome pearls that are probably a little more pertinent to the therapists and the clinicians. So this is the house of the spinal cord. It's made out of vertebra. You've got 7 cervical vertebra, 12 thoracic, 5 lumbar, 5 sacral, which are fused. And in the end, there are 4 coccyx vertebra. And this is the cushion around the spinal cord. The spinal cord starts at the foramen magnum, which is the base of the skull, and it travels all the way to the end of the coccyx. When we were all embryos, the way the vertebra develop and the lengthening of the spinal cord interrupts at a certain point in development. And what happens is there is a tail or a stretch of peripheral nerves at the end of the spinal cord. And that was termed the cauda equina, or the horse tail. And as you can tell, in most human beings, the spinal cord ends at L1, L2. So if you can see where it says conus medullaris, that's where your spinal cord ends, and then after that, you have your peripheral nerves exiting your vertebra, sending messages and communications to your lower body. There are 2 enlargements in the spinal cord that are really important. If you look at the top blue one and the top yellow-red one, there's a cervical and lumbar enlargement. And those are really important because right before my neck receives innervation to my upper extremities, there's a lot of guys that need to go out to my upper extremities, and that's why I have a cervical enlargement. Same thing can be said to my lower extremities. So you have a cervical and lumbar enlargement. So we know where it ends, we know where it starts, we know how it's protected. Hopefully, if there's something that I want all of you guys to take out of today's conversation and skill session, is this. Lots of people get this wrong. Lots of really, really smart clinicians get this wrong. So, terminology. We use tetraplegia and quadriplegia a lot in our diagnoses. The healthcare industry doesn't understand the difference between tetraplegia and quadriplegia. That's why they're interchangeable. I can't code someone with the correct term. And we need to fix that. And that's why everybody gets the terminology wrong. But this is what I want everybody to get. So, anytime the cervical spine has been injured, okay, and you have motor weakness in your limbs, you are a tetraplegic, period. You will not be a quadriplegic. A quadriplegic is someone who has functional weakness due to an etiology other than the spinal cord being affected. Okay? Now, paraplegics, we kind of get this right all the time. It's anytime the thoracic, sacral, or lumbar nerves have been injured. So we call someone a paraplegic. So, caveat pet peeve number 1, tetraplegia. I tell my residents tetraplegia, 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 and about 50% of them at the end of the rotation get it right because the terminology is just constantly wrong. But we need to fix that. Terminology number 2. You hear the concept of a complete and an incomplete spinal cord injury. We throw it around all the time. We are not allowed to throw that term around all the time. That is completely wrong and flawed. And we need to stop doing that. The only way you'll know whether or not a patient is a complete or an incomplete spinal cord injured patient is whether or not the rectal examination has been completed. The rectal exam, or the anorectal examination, tests sensation, both light touch and pinprick, to the anorectal junction and checks motor control of the voluntary anal sphincter. Those things must be complete for any of us to confidently say that this patient has a complete spinal cord injury or an incomplete spinal cord injury. And there's layers to that, but you can't get into the layers of the sandwich until you understand what the 2 toasts are, okay? Paraplegia, paraplegia, complete, incomplete spinal cord injury. Let's move on. So the report card, the International Standards for Neurological Classification of Spinal Cord Injury. It's a way in which, in 1990, we developed a standardized approach to grade a patient with spinal cord injury. It's a common language for a lot of us clinicians to use to communicate. Hey, I have an admission coming from DMC. They're a T6 Asia A. You already know what to expect, or you should know what to expect. A thoracic injury at that level means respiratory function should be intact. They may have bowel and bladder issues, and they're a complete spinal cord injury, meaning the sacral segments, voluntary anal contraction, sensation are not intact. So for sure, you should anticipate ISC, intermittent straight cath, needing a bowel program, needing to know how to transfer, become independent in a wheelchair, yada, yada, yada. Lots of juicy details we'll go into. Interestingly, the reason why especially if you work in admissions and you view a lot of these patient scenarios, the reason why you notice the terminology is wrong is because a lot of people graduated in 1992 and then things changed. And they graduated in 1996 and they changed. And quite honestly,
Same role.
huh?
Same role.
Yeah. They literally were just changed 2 months ago, and I had to recertify. Okay? So that's why we all get it wrong. But nothing has changed for a very long time in terms of deciphering a complete versus incomplete, and I doubt they'll ever take that away, ever. So store it somewhere in your neuron and just close the book. So when I said I had to certify, this is what I mean. This is a spectacular website for learning and training. And yes, I know usually it's just physicians that complete this training, but it's actually open to nurses and physical therapists, occupational, or literally any human being that would like to go through the training. It's super friendly, it's actually fun. Might take you about a day or so, but you'll so much, and it's essentially free unless you want the certificate. So just as a caveat, there is also training for skin conditions due to spinal cord injury. There's a spasticity protocol that you can look into just to kind of understand the dynamics of how much problems we have in terms of using the correct nomenclature for what is spasticity and what does it mean, because that's just Pandora's box. But anywho, people who are doing clinical trials have to score a patient with the Isinski. So they have to have what we call the in-step training certificate to prove that they're competent. So honestly, if you're trying to spruce up your CV, it costs $60, and then you can add that, and then you're just that much cooler. So when do we give the patient this report card? So you want to perform the Isinski from day 3 to day 7 for their initial. As you know, that is rarely ever completed. It gives the most prognostic information from day 3 to the first week. And you'll soon realize why it's not completed during that time period. It's a long, lengthy exam. Patients are sedated, not in the mood. You can't ever catch the patient when you're trying to catch them. But those are all excuses. At Michigan, I force my fellows to figure it out. You can come back and finish half of it sometime else. But I literally always say, I don't care. You must do, at minimum, the part of the examination that determines incomplete versus complete injury. Because that'll help me prognosticate how much time in rehab I need to make this person functionally meet their functional goals. Okay? And when I complete that part of the examination myself, and I'm trying to determine a complete versus incomplete injury, that's the moment in time where I literally hold my breath and hope and pray that I feel a voluntary anal contraction. Because when I get that, and remember, it's not tone, it's not your pelvic muscles that are squeezing due to the stimulus of that part of the examination. It's real, conscious, voluntary anal contraction. And when you get that, you just put a smile on your face. And I know every time I go in, I do that part of the exam, and I get nothing, I'm just like, oh gosh, okay, great. You know, and just move on. Because I know so much at that moment in time that the patient doesn't even know yet. Okay? When do we re-examine the patient? Back in the day when you could keep someone in inpatient rehab for about 6 weeks, now only about 3 weeks. We usually finish another exam at the point of discharge or in the outpatient follow-up. And then 6 months and 1 year, but these are not standardized times to repeat the exam. We get this question a lot. How much recovery should I anticipate, and to what length of time does this recovery occur? And just like the flip side of a coin, head and tails, for me, head is moving towards neurological recovery. Tails is for neurological deterioration. This report card is what helps you prove to a neurosurgeon that someone's deteriorated. Okay? Recovering and doing well is just a plus. Everyone's going to, put a smiley face on that. Wonderful, great. But the deterioration is what's really important. Because most neurosurgical physicians don't really want to believe that someone deteriorated after they've just opened them up. It's not a good outcome. 2 types of deterioration I want all of you guys aware of that care for patients. There is what we call tethering of the spinal cord. And remember that tail at the end of the spinal cord? Due to scar tissue or the fact that someone opened you up, there's an inflammatory cascade that occurs and scarring happens. So what happens is those peripheral nerves essentially attach to places where they shouldn't. Remember when we said the spinal cord ends at L1, L2? Well, on imaging, what you'll notice is that it's much lower now. It's ending lower, meaning someone's grabbing it and holding it down. Okay? Kind of like the Rockefeller Christmas tree. Just tethered, and then tethered much lower than you want, and it's like squishing things that it shouldn't. The other one is more common in the cervical segments, and that's the syrinx. And we don't really understand syrinxes very well, but they're very easy to point out. Patient will come to you and say, hey, I'm feeling way more numbness and tingling than ever before. It's different, something's wrong, and I'm dropping things. You do your exam, you might notice a smidge of weakness. You repeat imaging, and you notice there's a fluid-filled cavity in the cervical cord. That's the syrinx. So yes, when it comes to prognosis, we're always talking about recovery, recovery, recovery. But we all have to know about deterioration, because that's life-threatening. Okay? So if everybody could share looking at the report card. A lot of the times when I'm trying to bring a patient into inpatient rehab, I try to figure out, are they complete or incomplete? And I sometimes just ask for this. 15% of physicians have ever seen this, and even less have ever completed one. So usually, because we're kind of in the area where we're a little bit cush, spinal cord injury docs or PM&R residents should be competent in completing this examination. So I just want to give you one little caveat. There's a right side and there's a left side, right? You have the cervical, thoracic, lumbar, sacral segments represented in terms of motor and sensory function. But there's a really unique part at the bottom that's really bolded, okay? I can barely see it here. And the first part is voluntary anal contraction. The second is the sensory. Again, one of the things I want you to take home with is if you're ever looking at this report card, this is what you need to look at. If it says N or no for voluntary anal contraction, and you have zeros across the board, and then you have no for deep anal proprioception or pressure, that means you're a complete injury. And everyone's going to know how to do this now, because it's really simple. You just look at the bottom part, and you look for what we call a positive noon sign. N for no, 0, 0, 0, 0, 0, N for no, okay? And then we're going to kind of very briefly go over the other components of this part of the exam, and then we'll move on. So when you're classifying a spinal cord injury, you're going to obtain a sensory level. No one really cares about the sensory level, or at least the therapists don't really care about the sensory level. They're always asking me about the motor level. Dr. Beery, this person is I've got C6 wrist extensors waking up today, but you still call him a C4 spinal cord injury. Why is that? Why can't you change his grade? Because when we talk about a spinal cord injury, it is assigned based on the neurological level of injury, not the motor level, not the sensory level. The neurologic level of injury is the most intact level of both sensory and motor. They all have to agree. And just close your eyes for a second and imagine that cross-section of the spinal cord, okay? If all those three were intact, that means that's the highest part of the spinal cord that wasn't attacked or injured. That's why we call that the neurologic level of injury, okay? Everything downstairs where there's a blockage or an accident, there might be some diversions to go on a different exit for sensory or motor. But that point and the point above it, it's like the Australia fires. There's a point where there's like lots of chaos and things can exit and go to safety. But where the fire isn't is what we call the neurologic level of injury. And this is why sometimes you get a patient that I call a C4 neurologic level of injury, okay? But they have wrist extension, and that's C6, okay? So it's not fair, but that's just the report card style of grading a spinal cord injury. So sensory exam, 28 dermatomes on each side. Light touch is super simple. You just compare to the face, hey, this is light touch with a cotton swab or a Kleenex, and you go through the dermatomes. The part that everyone gets wrong is pinprick and dull discrimination. You have to be able to tell me the difference between pricky and dull for you to get a 1 or a 2. 0 means you failed. And residents get this wrong all the time. When the patient says, oh, I can feel that, they give them a 1. And no, we're kind of really harsh on this exam. You have to be able to discriminate pinprick and dull discrimination. There's a real reason for that. That spinal tract, the spinothalamic tract that allows everyone here to decipher between I just stepped on something pricky, ouch, versus, oh, I just stepped on something, but here, let me move my foot, okay? That tract lies near your cortical spinal tract, which is a motor tract. So you'll see at the end of the lecture that because they're so close together, there's an important prognostic indication to getting that part of the exam correct when the examiner is testing you. Okay? So it's the discrimination of pinprick and dull. Motor exam is super simple. You've got your C5 to T1 in the upper, and then your L2 to S1 in the lowers. They're what you'd expect, your elbow flexors, wrist extensors, and elbow extensors. The ones you probably don't know are C8 and T1. C8 is your flexor digitorum profundus, which is literally just this finger flexor. And then your T1 is abductor digiti minimi. Your lower extremities are what you would expect. Your hip flexors, knee extensors, ankle dorsiflexors. L5 probably one you wouldn't expect, but it is your long toe extensor. And then S1 is always going to be your S1, which is your ankle plantar flexors. The way we grade them is pretty standard, except when you're doing an ASIA exam, the patient has to be supine. Okay? And the starting point for each muscle test must start at 3. If you can't do 3, you move to 2. If you can do 3, you move to 4. So you don't start at 5 and move down. That's just the only caveat. So the reason I kept this slide in is mostly for the therapists. A lot of the times we have substitutions that patients are doing because they're really trying to get that movement correct for you and for themselves. And the wrist extension is one substitution of you supinating your wrist and us thinking you actually jerked your wrist up, okay? The other one is the ankle dorsiflexor. If you're putting your gastroc and soleus up, it might look like your extensor hallucis longus or your EHL went up. So just, just a little caveat. What about all those other muscles that start to wake up that everyone's excited about, except the ASIA exam? Okay? It counts for something. A lot of patients who have nothing going on in the legs, especially if they're younger, one of the first muscle to wake up is the adductor, your L2. That has prognostic value because it means after that crash we had in the highway system, some sucker in the L2 is going all the way down and sending innervation to the lower extremity, which is spectacular. So you do get credit for a non-key muscle group. It just doesn't change your neurologic level of injury, okay? I think I alluded to the sacral exam, and I think I've stressed it pretty strongly. If this part hasn't been done, you cannot call someone a complete or incomplete spinal cord injury. So we know the difference between complete and incomplete. There's absence of sensory and motor function in the S4, S5. And incomplete means that you have partial preservation. Anytime you have partial preservation, you are considered a sacrally spared spinal cord injury. There are two types of sparing. Either sensation is going down the pathway or motor is going down the pathway. This is the grades. If someone ever gave you the choice of what kind of spinal cord injury do you want to have, you say D. Doesn't make sense because it sounds like you failed, but you want to be a D. And so an ASIA A is a complete spinal cord injury. An ASIA E is someone who is completely neurologically intact after there was evidence of them having something not neurologically intact one time in their life. So everyone here is not an E unless you've had a spinal cord injury. So you've got your A, you've got your E, and in the sandwich you've got B, C, and D. And I said you want to be a D because a D is where half or more of your key muscle groups below your neurologic level of injury are pretty strong. They're 3 or 5. You also want to be a D because it has a spectacular prognosis for ambulation. When I'm able to complete an ASIA exam on a patient I'm seeing in the ICU and I D them, I literally tell the wife or the husband or whoever's in the room, let me tell you how this is going to work out. It looks horrible right now, but especially if you're less than 50 years old, you're probably going to walk out of rehab in about 3 to 4 weeks. I have the stats to say that very confidently. When I A someone, I try not to have that conversation at that one moment in time because it's really, really difficult. This is the difficult conversation where a lot of things can change, and I'm going to go over the prognosis with you. But I either have that wonderful, I have the D conversation, or I don't unless I'm asked. So sensory incomplete is a B, meaning you get some credit because sensation is moving down. But since D and E is where we want to be, a C has motor going down. Okay? So now that we've classified A, B, C, D, and E, whenever you're watching television, something dramatic on television, some guys in the ICU, everything's beeping, the rhythm strip on the television is completely impossible because it's Hollywood. The first thing the patient says when he wakes up out of a coma, "Doc, am I going to walk again?" And maybe we all or some of us think that that's what everybody asks. And it's true, in the acute phase of a spinal cord injury, they do ask that. But when they come to rehab, you want to know what they're really, really worried about? Am I going to control my bowels? Am I going to urinate when I want to? They're really concerned about continence. The second you get their bowel and bladder program semi-stable, then they start asking, am I going to walk again? So what do we know? Are they going to walk again? So the functional prognosis for a complete spinal cord injury. So there's a huge difference between what a C5 and a C7 neurologic level of injury can do, as you guys know. You should expect at the 1 year mark, let's say my motor level was C4, you should be able to envision that my biceps will wake up on average. How much will they wake up? Will they be a grade 2, a grade 3, a grade 4? Probably a 3. Now what if I was a C4 and my bicep was already a 1 or 2? Then you know that guy is going to be functional by the 1 year mark, which is nice. In an incomplete spinal cord injury, about 90% of patients do get 1 or 2 motor level increase. The type of incomplete that you are, if you're a motor incomplete, you're going to get much more recovery. If you're a sensory incomplete, you're going to get less recovery on average, right? This is important. I think this is easy to remember, and I'm just going to tell you what I tell my residents. So remember, your ASIA exam was done in, hopefully, by day 3 or the first week. You want to be a D, because you're going to be ambulatory. Pretty decently ambulatory. An ASIA A converting to an ASIA D at the 1-year mark is 0 to 5%. Okay? Remember how I said it's important to understand pinprick dull discrimination because it gives you a prognosis? If you looked at the patient's ASIA exam and you saw that they had some pinprick dull discrimination in the sacral segments, that person has at least a 35% higher chance of ambulating than someone who just had light touch. Remember, because they're close to the motor tracks. And then in ASIA C, it's kind of like, remember, well, I hope you guys never got a C at an exam, but it's usually 75 or 70%, right? So they have, at the 1-year mark, a 70% chance of becoming or converting into an AISD. So A is like 0 to 5, B is like 50-50, and then C is about 70%. Now, I told you about how, because, you know, A's are the worst off. So I want you to understand another thing. At 72 hours, so we talked about an A becoming a D is like, you know, very rare. I've never seen it, okay? But an A could become a B and a C, and it's about 10% chance each way. If you're younger, that increases a little bit more. Just like in a traumatic brain injury where we have this concept of neuroplasticity or your body healing its nervous system on its own and recovering. In the youngsters, especially an 18, 19, 20-year-old, there's neuroplasticity in the spinal cord. This is something about 15 years ago we didn't really understand. So the A's that actually convert to have walking function are really your A's who are thoracic levels, like T11, T12. So don't think about the C4s who are event dependent getting into that 14% mark, okay? Now, B's are your 50-50, right? I did mention the pinprick dull discrimination for walking recovery. C's are your 70-75 percenters. If they're younger than 50 years old, remember how I said 60 to 75, but if they're less than 50, you're looking at a 90% where they become some form of ambulator, either household or community. And we all know how we feel about D's, right? It's funny, it's always like patients don't believe you when you tell them, hey, you're an AISD. I think you're going to walk out of rehab because the systems that we have that track patients with these injuries show that. When you look at the percentage, so these are kind of like the really famous studies that were done that show prognosis for recovery. When you look at motor incompletes or ASIA Cs, if they're greater than 50 years old, it's not like a 50-year-old is necessarily less healthier than a 30-year-old. But if you're greater than 50 years old, you usually have more comorbidities that are cardiopulmonary, and those affect your ability to deambulate. So if you're 60 and you're literally doing marathons, you're not in that group. So the last thing I wanted to go over is this packet here. And what I really wanted to showcase is the valuable information available after you've done the report card on a patient. And this is, again, like mostly for therapists and like the clinicians. But when a patient is a C1, so this is released by the Paralyzed Veterans of America, and this is like the gold standard in terms of expectations of a patient with whatever neurologic level of injury they have. And this is important for letters of medical necessity or when you're fighting with an insurance company for coverage, because you can just slam them with this, and if they don't, if they literally still deny coverage, then they're really not providing care. So for example, what are you going to expect for someone who's a C1 to a C3 level neurologic injury? Well, your diaphragm is innervated by C3, C4, C5, so you know most likely they're going to be vent dependent. But what are you going to do with them in rehab besides range them and teach the family to use a mechanical lift? Well, you could obtain independence in their wheelchair. If you're lucky, if their sip and puff is okay, you could get them to be independent in pressure relief. So my residents get real annoyed. What am I supposed to do with this person in rehab? They're event dependent. What are we supposed to expect? And I say those are two real good goals. Pressure relief and mobility. If you look at the C4 neurologic level of injury, it doesn't have any really large areas of concern, except maybe they'll be weaned off the ventilator when they come to inpatient rehab. Now, if you look at the C5 and C6, if you look at the equipment, especially for my OTs, there are some really interesting equipment, especially when it comes to eating, like your long opponent splint and adaptive devices, whether or not a patient does have wrist extension or not. So it's kind of a guideline, like when you're developing a therapy plan, this is like your cheat sheet. Now, these are kind of in red. I know that we have a lot of legislative reform coming up, and I know that a lot of patients at a certain neurologic level of injury, even thoracic and lumbar, still think they need it 24/7 attendant care. And the reason why auto covers attendant care at one level and regular insurance companies don't come from these studies. So a patient who is a C7 spinal cord injury, but 29 years old, 25 years old, less comorbidities, should be able to live fairly independently without the assistance of an attendant. And again, these are just little caveats. These are ideal situations. Someone with a C6 spinal cord injury who doesn't have abdominal girth, who doesn't have cardiopulmonary compromise, should be able to straight cath independently. I know it's kind of rare, but goodness forbid that any of us had a spinal cord injury. We would be super motivated to hit these landmarks for recovery. And if you do go to, so there's C8, and then we get to the thoracic. And the only thing I wanted to highlight in the thoracic level of injury is, the standing program for some of your therapy goals. And to summarize, the International Standards for Neurological Classification of Spinal Cord Injury was developed so that we can communicate with family, with clinicians, with the multidisciplinary team about expectations and outcome for spinal cord injury. It gives me a cheat sheet when I examine a patient at day 3 or 4 or 5 up to day 7 in terms of really looking into their crystal ball if things keep up at a trajectory. So it's good to know how to do it. It's also the standard for clinical trials, figuring out whether or not an expected outcome for a certain manipulation helped a patient improve their motor or their neurologic level of injury. So complete versus incomplete, expectations and prognosis. A, D, okay? And then the sandwich in between. And you do want to be a D because those ambulate literally out of rehab at the 1-year mark. close to about 97% at the 1-year mark are ambulatory, regardless of age. Okay. So I hope you guys learned something. Anyone have any questions? If you do, I'm here on Thursdays, half days usually. Just drop in. All right, thanks guys.